First, we will look at some contextual factors that are affecting the South Korean healthcare system. South Korea faces major demographic changes, with its population declining and aging rapidly. Those aged 85 and older will quadruple by 2050, and this shift increases health system strain as a smaller workforce supports more older residents. Non-communicable diseases account for over 77% of deaths, driving long-term care costs higher. Economically, recent GDP growth and rising healthcare investment provide opportunities, but also add pressure to government budgets as care spending rises. Rapid technological adoption, including telemedicine, can improve efficiency, though rural-urban divides may worsen inequality gaps. Politically, ongoing reforms aim to expand workforce and improve access, especially for underserved communities. Environmentally, air pollution raises stroke and heart disease risks, straining hospitals but also justifying prevention initiatives. Socially, Koreans visit doctors 2.5 times more than the OECD average, promoting early detection but increasing system burden. This map illustrates how contextual forces shape South Korea's healthcare over different timeframes. Demographic changes, like the shrinking aging population, will have major long-term effects, increasing care needs and financial pressures on workers. Epidemiologically, patterns add continuous strains, as non-communicable diseases already cause most deaths and drive costly, resource-intensive treatment. Economic pressures, including rising health spending, will increase fiscal demands over the next few years, despite modest GDP growth. Social factors, such as Koreans visiting doctors 2.5 times more than the OECD average, impact the system immediately through higher service use. Technological advances, especially digital health and telemedicine, are rapidly transforming care delivery now. Ecological issues, including the 19% increased risk of cardiovascular deaths from pollution, add slower, long-term strain, but also justify preventative action. Finally, ongoing political and legal reforms to insurance and workforce will shape medium-term change. This will create opportunities for better health outcomes and equity.
To evaluate Korea's performance, I compared it with the following three developed countries. Japan is chosen because it is a neighboring Asian country with a similar demographic pressure and similar hospital-centered service use. Germany represents a high-resource benchmark with social health insurance systems similar to South Korea. And Australia is Asia-Pacific developed country providing a contrasting model with tax-fund Medicare, allowing us to see how different systems are designed and chosen to affect different outcomes. Starting with health outcomes, Korea performs very well on clinical side. It has high life expectancy and lowest treatable mortality among these countries. But Korea also faces major public health and behavior challenges. It has the highest suicide rate and highest physical inactivity, both much worse than Japan and Australia. In terms of responsiveness, Korea excels in access and timeliness. It has some of the fastest specialist waiting times, with high hospital bed supply and the highest doctor consultation rate, but the system struggles with continuity. Only 27% of the people have a regular doctor, compared to over 80% in Germany and Australia. Rural doctor density is also very low, showing that persistent regional inequality exists. South Korea performs the worst in financial protection. It has the highest out-of-pocket share and highest catastrophic spending, and the largest mental health treatment gap. Germany and Japan demonstrate that SHI system can protect households better when public coverage is deeper and benefit packages are broader. In summary, Korea's strength lies in biomedical care quality, timeliness, hospital service capacity, and high investments to prevention. Its challenges reflect structural issues, major public health and behavioral risks, fragmented primary care and poor continuity, weak financial protections, and regional inequalities in access. Based on these challenges, South Korea's health system could draw on these following goals. First, it can strengthen population health and reducing preventable mortality. Second, to improve continuity and coordination of care. Third, it can enhance financial protections. Finally, it can strengthen equity across income groups and regions. Together, these four goals directly address the system's major weaknesses while moving Korea towards a more equitable, resilient, and people-centered health system. When looking at stewardship, the graph shows that Korea operates as a powerful financing model, where the National Health Insurance Service has the strongest influence on funding and purchasing. The Ministry of Health and Welfare sets strategies but has less operational control, and providers, which are mostly private hospitals, depend heavily on NHIS. The imbalance contributes to Korea's structural issues as well. It has the high utilization under fee-for-service, high out-of-pocket payment, and weak primary care. Also, it has limited integration. South Korea's organizational structure also explains many performance patterns. The system is highly centralized, leaving regional authorities with little power over planning or workforce allocation. This leads to Seoul being overconcentrated, with specialists and rural regions remaining underserved. Integration is weak. There is no gatekeeping, primary care is fragmented, and services operate in silos. This causes duplication, poor chronic disease management, and contribute to high preventable mortality. An intense competition under fee-for-service drives high utilization but short consultations, weaker quality, and clustering the providers in profitable urban areas. Overall, these organizational and stewardship features are closely tied to the performance challenges we observed across using the data comparing to other countries.
South Korea finances its healthcare system through a mandatory social insurance system. This is called the National Health Insurance, which functions as a single-payer scheme covering virtually all residents for core services. NHI is funded mainly by income-based contributions from employees and employers, plus contributions from the self-employed, with additional government subsidies and earmarked tobacco taxes. Around 60% of total health spending comes from government and compulsory schemes, while roughly 30% is paid out of pocket, mostly as co-payments and for non-covered services such as some advanced cancer drugs, dental or specialist care. This high out-of-pocket share exposes many middle-income households, those not eligible for medical aid, to financial strain despite universal coverage. Evidence using Kakwani indices show that these direct payments are regressive, meaning poorer households spend a larger share of income on healthcare, especially for outpatient care, medicines, and increasingly for dental services. So Korea combines strong risk pooling with persistent equity and protection gaps.
South Korea's healthcare resource allocation can be discussed in two dimensions. First, by sector. The system is dominated by the private medical sector, with about 90% of medical spending flowing to private medical institutions, while public medical institutions only obtain about 10% of the total resources. In terms of medical use, 97 to 98% of outpatient services are provided by private clinics. Public hospitals, however, mainly serve vulnerable groups such as low-income households and the elderly due to their lower fees. Overall, resource distribution reflects profit-oriented demand rather than an allocation based on health needs. Second, in terms of regional allocation, the image shows the distribution of private and public hospitals in South Korea. It shows that medical resources are mainly concentrated in Seoul and some major cities, resulting in about 25% rural patients need to travel outside their residential area for medical treatment. Since the introduction of national health insurance in 1977, South Korea has mainly used a fee-for-service payment system, where providers are paid based on the number of services delivered. This model covers most outpatient and inpatient acute care and tends to drive up both service volume and overall healthcare costs. In South Korea's healthcare system, which is dominated by private hospitals, physicians are often evaluated based on the revenue they generate. This encourages them to prioritize high-profit services or non-covered services, illustrated by the high rate of catering section. However, South Korea also has introduced a DRG payment system, initially mandatory for 7 diagnostic groups and applied mainly to small providers. The system was expanded in 2013 to larger institutions. More recently, in 2019, South Korea launched a new DRG model, which covered 4 more disease categories, with 98 hospitals participating by 2020. South Korea now has 97% of its population enrolled in NHI, a major increase from 8.8% when the system began in 1977. Service providers include public and private hospitals, clinics, and pharmacies. NHI covers most essential medical services, such as diagnosis, treatment, surgeries, while non-medical operations such as cosmetic surgery are excluded. In South Korea, patients can freely choose any hospital without a referral, so they generally prefer large hospitals, believing that they offer higher quality care than primary clinics. Clinics are allowed to operate inpatient wards, and hospitals deliver extensive outpatient services. This blurs the functional boundaries between providers and create competition instead of the hierarchical, cooperative structure in Western countries. South Korea is facing a shortage of healthcare professionals. Currently, there are only about 2.6 doctors per 1,000 people, with particularly severe shortages in essential fields. For our recommendations, firstly, to address South Korea's shortage of healthcare professionals and serious urban-rural disparities in medical resource distribution, the government can adopt a model similar to Japan's regional quota system. Under this approach, Japanese medical schools allocate specific admission quotas for students who are willing to work in underserved regions, offering scholarships or tuition reductions in exchange for a mandatory service period in designed areas after graduation. Secondly, Korea can improve satisfaction by strengthening primary care continuity, extending consultation times, and introducing national patient experience standards, addressing the current perception of rushed, fragmented care. Japan's higher satisfaction comes from its long-term community-clinic relationships and mandated longer consultations, which Korea could adopt by incentivizing family doctor enrollment, and revising the fee-for-service schedule to reward longer comprehensive primary care visits. Australia's GP-centred Medicare model improves satisfaction through guaranteed low-cost access, annual patient experience reporting, and funding for longer consultations approaches. Korea could mirror by expanding NHIS coverage for longer visits, publicly reporting patient experience metrics, and introducing GP-led care coordination incentives. Finally, Korea should reduce out-of-pocket payments for essential and high-cost care, expand NHI coverage and annual co-pay caps based on income, and streamline access to catastrophic expense support, reforming contribution rules for self-employed people, and systematically investing tobacco sin tax revenues in prevention will help strengthen financial protection and equity, ensuring the health system remains sustainable and fair.